Thank you very much, Dr. Saslima. Today is the 6th September, 31st death anniversary of our national professor, Dr. Muhammad Ibrahim, who is also the founder of this organization. Uh, Before starting, I am showing my deep homage and tribute to our national professor, Dr. Muhammad Ibrahim, and also a deep respect and tribute to those who have lost their lives during this current COVID pandemic, especially the healthcare workers. Respected President of the Diabetic Association of Bangladesh, Professor A.K. Azad Khan, Secretary General Muhammad Saifuddin, distinguished speakers from home and abroad, and the dear participants, organizers, and moderators. Uh, Before starting, I'm requesting Dr. Taslima, the moderator, to say a few words or short biography of the speaker, Dr. Nazmul Kabir Qureshi. Uh, Dr. Dr. Taslima, please, a short biography of the speaker.
Speaker Dr. Nazmul Qureshi is the Center Director and Consultant, Uttara Executive Center, National Health Fund Network.
So this is the first time in the history of Diabetic Association of Bangladesh that the national conference is being organized digitally or virtually. I think this has got a special attention, and it is well organized. So far, I observed that the session or the program since yesterday, it is beautifully arranged. I am congratulating the organizers and expressing my thanks and gratitude. It's beautifully arranged, even the advertisement and etc. etc. Thank you very much. Now I am going to the speakers. I am requesting Dr. Nazmul Kabir to present your paper, please. Dr. Nazmul Kabir.
Thank you, sir. Am I audible?
Yes.
Thank you, sir. With the kind permission of the chair, I'd like to start my presentation. So, distinguished chairperson and learned audience, Assalamu alaikum. We are in almost at the end part of this virtual conference. Today, I'll be talking on a very important topic, I must say, that is the impact of cardiovascular mortality morbidity in diabetic patient and what our drugs can offer for our patient. So let me allow me to share my slide, please, at first. So I think my slide is visible. So I'm going to carry on. Today, title of my topic is anti-diabetic drug addressing the cardiovascular mortality and morbidity. We know globally the incidence and cost figure related to the diabetes mellitus treatment, management, investigation, everything is increasing day by day. And most of this the burden is coming into countries like us, the developing world. And the major goal of treating diabetic patient with the glycemic control, the controlling the risk factors, and as well, we are also concerned about preventing the end organ complication. And that makes the ultimate goal of treating a diabetic patient, because the patient is, doesn't suffer from HbA1c, high HbA1c. It is nothing but the reflection of the bad impact of which it can cause to the target organs. So particularly among that, we know that reducing HbA1c and controlling other factors gives much a diabetic patient in terms of improvement in the microvascular complication. But even a few years back, we didn't have enough enough hope regarding the good outcome in terms of cardiovascular mortality and morbidity. Recent years, the paradigm has been changed, focus has been changed, and a lot has come into the treatment of the diabetes. So we shall focus on that today. We know that diabetes doesn't come alone. It comes with multiple morbidities or give rise to multiple morbidities, or it is a part of a metabolic syndrome. 50% of the patient eventually develop hypertension, and almost equal amount of patient develop CKD and also suffer from dyslipidemia. And all these things ultimately give rise to a higher incidence of mortality affected by cardiovascular disease. So we have seen, if we consider the macrovascular complication of diabetes, the spectrum of diabetes starts from simple affected coronary artery, then that gives to coronary artery disease that may eventually give rise to heart failure. And it has been seen that in various studies
কি খবর আছে
that
এখানে
cardiovascular
কি
disease is found 2 to 3 times higher when compared with the general population. However,
এটার
one
নাকি
well-known CKPDA study have shown that uh,
হ্যাঁ
intensive glycemic control gives many beneficial
দেখে
effects,
তো আর খুললো না
but however, it doesn't affect the mortality which has been uh,
সকালেরটা কি আছে
mostly affected by the cardiovascular complications.
হ্যাঁ
Please keep mute all. Don't accept the speakers, please.
আচ্ছা এখানে আর কি আছে
Please continue.
So now, for the last
এটা
few
কি দই
years,
দইটা নিয়ে আসো
we have seen very landmark
হ্যাঁ
studies which has shown that for few very interesting and few positive findings. We are now finding that
দেখি
even while we treat our diabetic patient with some specific regimen and specific style, it may change this
তুমি এটাই
bad
একটা
impact.
প্লেটে করে গরম করে নিয়ে আসো
Sir, Saifuddin sir, please mute your microphone. Saifuddin sir,
এই ওই
please continue this.
Okay, let us see a large-scale study which had been done in the Sweden. Almost 3 lakhs patients were studied regarding among the type 2 diabetic patient, and they were studied according to the age categories and the main confounding and affecting factors of 5 risk factors. Plus, the patient was seen how they are doing with the high HbA1c level when they have
Nazmul, please a bit একটু জোরে বলেন
when they have elevated low LDL cholesterol, albuminuria, smoking, and when they have elevated blood pressure, and what was the relation of this factor with the cardiovascular outcome. So it is now okay.
It's okay.
Okay, so among the patient with type 2 diabetes who have all the 5 these variables within that target range showed a positive effect when the study was in terms of hazard ratio. So the conclusion was that when we control not only the HbA1c, other parameters as well, type 2 diabetic patient have a little or no excess risk of death, myocardial infarction, stroke, and when compared with the general population. So eventually, now we talk much about the major adverse cardiovascular event. Nowadays, a simple antidiabetic drug with a good HbA1c potentiality is not good enough for us. We not only look for the potentiality of the HbA1c level, we look for how they are offering our patient cardiovascular safety. So these are the drugs are commonly used: insulin, sulfonylurea, metformin, and pioglitazone in our country. And though they have a wide range of capacity of reducing HbA1c level, but when the impact of the major advanced cardiovascular event is studied, we see there have been a not a, superior or inferiority uh, effect while we use this insulin and sulfonylurea. They are not doing harm, and but they are also not giving any protection in terms of major adverse cardiovascular events or heart failure. However, metformin and pioglitazone shows a reduction of the major adverse cardiovascular event. However, pioglitazone, rosiglitazone, they have shown some detrimental effect in terms of heart failure. So, then other changes and finding came when the newer class of drug has been invented and came into the treatment of type 2 diabetes. So today we'll mostly focus on these studies and the outcome and how they have changed the paradigm of treatment of diabetes. So the focus of the next part of the presentation will be on the SGLT2 inhibitors, GLP-1 receptor agonists, and DPP-4 inhibitors. So this is now we have among us while we start our treating patient type 2 diabetic patient. Lifestyle modification and metformin are in the as in the before they were, but thereafter we now try to define our patient whether they have established atherosclerotic cardiovascular disease or CKD, or whether they do not have. If they do not have, again we try to categorize the patient if they need to minimize the hypoglycemia, or there is a concern about the weight gain, or there is a concern about the major issue is cost. So this is how the categorization of the treatment pattern has been changed. How this change has been done, we'll see in the later. These are the studies: cardiovascular outcome study, the cardiovascular outcome trial. These were not much talked before 2008, but after 2008, this type of study has been mandated for any new drug that comes into the treatment of diabetic patient. So they are designed and powered to assess the non-inferiority versus when they're compared with the placebo, and where the standard of care were given in terms of high risks of cardiovascular in terms of cardiovascular outcome and heart failure and mortality and morbidity. So there were studies among the patients who have pre-existing CVD or have high risk of CVD, and we will see in the later study how far this study has gone. So this study actually focuses on three points, or sometimes 4 points, which are called 3-point MACE or 4-point MACE. These are the history of this kind of studies starting back in 2013, and still a lot of studies are going on. Latest study has been published in 29th August of this year, and we'll see on the how these studies are. We can see that almost all the commonly used modalities of treatment of diabetes has undergone this sort of study, starting with the EMPERAGE up to the EMPEROR reduced outcome, which has been published only a few days ago. So let us go first into a clinical situation. A 62 years type 2 diabetic patient who had diabetes for 8 years, taking metformin 2000 milligram per day. Recently been hospitalized for acute coronary syndrome and treated accordingly. And she was found with mild diastolic dysfunction with ejection fraction 48%, and all the other risk factor were treated accordingly. GFR was 76, HbA1c at the time of admission was 8.4. So what to offer for this patient? That is the question. So we'll try to find out the question after reviewing the studies. So I'll start with a very well-known EMPERAGE study, EMPERAGE trial, and this is a randomized trial. It was patient were equally divided into 3 groups: placebo, empagliflozin 10 milligram and 25 milligram. And inclusion criteria was type 2 diabetes with a BMI not more than 45, HbA1c ranging from 7 to 10, and they had established cardiovascular disease. And key exclusion criteria was HbA fell less than 30. So the trial was assessed in terms of primary outcome, 3-point MACE, and also second 4-point MACE. So this was the outcome. Uh, if we consider the primary outcome, we find a statistically significant superiority in the group of people who were treated with the empagliflozin 10 milligram and 20 milligram. And we also the other parameters you can see all they have show is more or less significant results. If we go into detail, that we see that according to if we consider 3-point base, that is CV death, non-fatal MI, and non-fatal stroke, there were 14% relative risk reduction in the group of the patient who taken empagliflozin 10 milligram or 25 milligram. If we subdivide, we find the similar results. And of course, eventually it gave a very, very good outcome considering cardiovascular death. There is a 38% relative risk reduction. And all-cause mortality was also, there is 32% relative risk reduction. One thing is that very important that heart failure hospitalization has been tremendously reduced with this group of people who taken the empagliflozin 10 milligram and 20 milligram. And this is very interesting that all this beneficial effect, particularly when as it was assessed for hospitalization for heart failure, all this effect, particularly the heart failure beneficial effect, started. If you look at this, the circle that started very early phase of the study. That means patient got this beneficial effect very early. Of course, there was significant regression of the HbA1c, systolic blood pressure, and body weight showed a beneficial effect. So we can, if you can just review the strategic plan for treating diabetic patient, almost all the parameters, all the section they have covered while offering the treatment for type 2 diabetes. Not only that, they showed a beneficial favorable effect in terms of renal function when they were subdivided according to the eGFR level. However, the exclusion criteria was less than not less than 30 millimole per minute were not included. So up to 30 to 60 even, they showed a beneficial effect. They had some adverse effect, but regarding hypoglycemia, decay, and bone fracture, there were no significant adverse effect. And another thing is that the study was not in type 2 diabetes who did not have cardiovascular disease and not among the patients who had newly diagnosed type 2 diabetes patient. So if we consider in a summary that this is one kind of important landmark study which shown not only cardiovascular safety, which was its initial outcome or target, it showed some beneficial effect. That was not planned or even thought before implementing this kind of study. So we found a very beneficial effect in terms of cardiovascular death and most important, heart failure. So another similar kind of study done with the canagliflozin. They were done in a larger amount of population, and this study was published in the later after in 2017. Another group, another type of drug of same group, similarly shown the 14% reduction of the 3-point MACE. So this was the comparable slide. So if you compare with the graphs of EMPOWER trial, and we also find here significant difference. And if we compare with the EMPOWER, there's a reduction in death from cardiovascular cause, but probably it is not as much big as EMPOWER trial. However, 3-point MACE are still in the correct side of in favorable point of canagliflozin. Regarding heart failure, as in EMPOWER trial, there is a big reduction in the hospitalization for heart failure as well. And also it showed a beneficial effect similarly like EMPOWER trial. and it was found that here the reduction of the albuminuria helped a lot in reducing the uh, in giving the favorable outcome in terms of renal outcome. Similarly, it showed beneficial effect in reducing HbA1c, body weight, and systolic and diastolic blood pressure. So, if we summarize that, even canagliflozin showed a similar kind of beneficial effect and outcome as well. And another, last of all, another trial this published in 2018, the done with the dapagliflozin, even with a higher number of population and higher duration of study. One interesting is that in this study, there's 59.4% had risk factor for atherosclerotic cardiovascular disease, but not established cardiovascular disease. So it is another type of attitude was shown in this kind of study. Here you can see that among the patient established atherosclerotic cardiovascular disease, the rate of MACE was 13.9 compared with the placebo 15.3. Among who had the multiple risk factors, not established cardiovascular disease, the rate was like 5.3 and the 5.2 respectively. So there was a significant lower rate of cardiovascular death or hospitalization for heart failure than when compared with the placebo. So here again we find that though the MACE was not significant, but there is a significant lower rate of cardiovascular death and rate of the significant reduction of hospitalization for heart failure as compared with the placebo. This is the one the comparable slide. So here again it showed a favorable composite renal outcome. So again, regarding heart failure and regarding the other renal outcome, MACE outcome, renal outcome, we see the dapagliflozin were in the favorable side. So last of all, another important study just published a few days ago, and the very interesting is that in this study, only 50% per person had type 2 diabetes. In other words, 50% did not have type 2 diabetes. That is one important thing. And they had a mean of left ventricular ejection fraction 27%, and they had a GFR as before, like less than 60, 14%. So these are the inclusion criteria. So this study was done among those who had a reduced ejection fraction, and it showed a favorable effect in terms of cardiovascular death, heart failure hospitalization, total hospitalization, composite renal outcome, all-cause mortality. And another important thing is that among the patients who are studied, not diabetic, new onset of type 2 diabetes among onset of type 2 diabetes among the patient with diabetes, type 2 diabetes was 11.2% when compared with the placebo, 12.6. So this is an important thing, whether we should think that this drug can even prevent or delay the onset of type 2 diabetes as well. So now we are going to another molecule. This study was done on the GLP-1 receptor analog, similar kind of study, and almost like a similar kind of results. However, the comparable slides we see all showed the superiority in terms of primary outcome uh, and death from any cause. But important is that here, if we compare with the other molecule, SGLT2 inhibitor, the significance of hospitalization was not that significant. It's like not in favorable side regarding hospitalization for the heart failure. So in the primary outcome, this panel shows there is a good improvement in terms of MACE and in terms of death from cardiovascular cause. However, heart failure, it didn't show much improvement. So if we conclude that the leader trial showed no improvement in heart failure, though it showed a good improvement in terms of MACE. Another important is that in terms of reducing the major cardiovascular event, it took a bit longer times when compared with the SGLT2 inhibitors. So SGLT2 inhibitors gives a rapid outcome say. So also it gives a good renal outcome, and there is a very good reduction of new onset of macroalbuminuria. So this prototype showing that CVD benefits in this trial had existing cardiovascular disease a good outcome, but in terms of heart failure, and it didn't show a much good outcome. So now, the last of all, the DPP-4 inhibitors, similar kind of uh, cardiovascular outcome trials done, and they showed neutrality. However, in one study, there's successively they showed higher rate for hospitalization for heart failure. So there has been a reduction in the development and the production of macroalbuminuria in some trials, but perhaps it was due to the glycemic control. So if you summarize that, they showed uh, not much beneficial effect in terms of heart failure, and though they showed no detrimental effect except susceptibility. So this is how this uh, stratification of treatment or approach to treatment has been developed. If we find out, this is a kind of recapitulation that if we find out any indication for addressing the atherosclerotic cardiovascular disease or security or heart failure, or we find any risk factor, we have to think twice if the cost permits that on which approach we should go. We should not only think of we should not only think of HbA1c. We should also try to give our patients some beneficial effect, so they can have a reduced rate of mortality, morbidity, and heart failure as well. So I am at the end of my presentation. If I try to summarize that, we have many drugs in our hand to treat our diabetic patient. Uh, some beneficial effect we always found with the metformin and pioglitazone, but if we specifically think of cardiovascular mortality, morbidity, safety, protection from heart failure, there are other classes of drug. DPP-4 inhibitor may not be that potential to give this beneficial effect. However, have a compelling indication while we want to avoid hypoglycemia or weight gain. And another important drug is GLP-1 receptor agonist. They improve all the MACEs. However, they do not still have shown any beneficial effect regarding heart failure. Renal protection is good, and we can give this patient through wide range of EGFR level. So we should think of adding this molecule to our patient when heart failure is not an issue. But when the all issues come, and if the EGFR permits, then the SGLT2 inhibitor molecule can be a fantastic one in the rapid. I must say it's a rapid lowering of the MACE, rapid lowering of the all heart failure, and all the beneficial comes very rapidly than when compared to the other molecule. Uh, then what will be the suggested answer for our case? The patient had both ACS and mild heart failure along with the microalbuminuria. So probably SGLT2 inhibitor, if the patient can afford, can be a good one. Lifestyle modification and efforts should be there. And of course, some can also argue for the therapy of GLP-1 receptor agonist that may be appropriate for reduction of HbA1c, though we have to keep in mind that that does not have enough heart failure benefit. So thank you very much for patience hearing.